So I thank again. Now I welcome Professor SUSHMITA KAUSHIK for giving glaucoma drainage devices in a challenging situation. And ma'am doesn't require any more introductions, and she's very dynamic pediatric glaucoma specialist in the PGH Chandigarh. Welcome ma'am again.
Thank you, and thank you, Dr. Faisal, for having me on this wonderful course. And good morning for those who've come. Glaucoma drainage devices in children are an armamentarium that we have, and believe you me, they do preserve vision in children. As we've grown older, we try to avoid it more and more because we know we have a long way to go. But as the baby who came to me, and now he's about 17 years old and soon going to college. But if you see the visual field across, now we've done CTT, then we've done a retrap, then we've done a tube in one eye, then we've done a tube in the other. So no matter what you do, sometimes these children, require hand-holding lifelong. And as we've been there for so long, their parents become our friends and the children become ours as well. But just to illustrate, over these 17 years, you see his disc and his fields have sort of held on. So we are just keeping our fingers crossed. And there are many, many babies who would require this. So there are bad VKCs, there are bad anterior segment dysgenesis, there are some Sturge-Webers also. So you do land up in situations where you would need them. So I found this, during the course of this talk, I found this very interesting article comparing, in the same time period, glaucoma drainage devices in children compared to that in adults. And this was a comparative study of outcomes and complications. So the problems in children is there's eye growth, that's one, and we need to remember that the position where you've put the tube today may change as the eye grows. And sometimes the tube migrates in, sometimes the tube retracts out, depending on the various rates of growth of the eye, whether it's anterior or posterior. The children have a tendency to rub, and of course they're more propensity to trauma because they're children. They will play, they will go out, they will fight. So they had 69 eyes of children and 145 eyes in adults, and all of them had either a Barvelt or a Molteno. So interestingly, the efficacy was similar. So you can see the Kaplan-Meier graph is very, very similar in both of them. But the complications that were more in children were tube retraction or migration. So that's something to keep in mind. Encapsulated blebs were more because they throw a more virulent anterior chamber reaction. And endophthalmitis was more. And I suspect it's because of the rubbing and the trauma, where exposures are also more. And in adults, the corneal decompensation was more. So that's also intuitive because in adults already the endothelial cell count is on the decline. So you're starting off with a lesser endothelial cell count vis-a-vis the children where probably it's more robust. So let's look at the problems of tube placement. One is that the limbus, by the time you get down to doing a tube in children, the limbus is very, very stretched because you've tried lots and lots of things. So this is actually a 5.5 millimeter limbus in a child with anterior segment dysgenesis. So the anatomy is really distorted. You're never sure of where you're entering. Then the sclera is stretched, thin, elastic. So fashioning a long tract is really tricky because they're not going to respond the way you think they would. And of course, as we said, migration and retraction due to eye growth is a problem. So the optimal length to put in is a little unpredictable. So for instance, this girl, again, one-eyed, she required two. So we put one and we put the other. And by the time she came back to us a couple of years later, both had actually migrated into it. And we had to go in and trim it, which is easy to do, but then it's something that has to be kept in mind. So the quadrant placement needs planning. Post-trauma, if you have an open globe injuries like this kid with retinal detachment and silicone oil. So silicone oil, if you're going to put a superior tube, the problem with that is that it's not going to block the tube, but the emulsified oil, if it goes out into the conjunctival or subconjunctival space, it's likely to cause fibrosis and your tube is likely to fail. So I'll just show this child that we did. This is how we do an inferior. So this, of course, is a very, very traumatized eye. And this is how the inferior Adi was placed. And I'll just fast forward this a bit. So you need to cut it. I like cutting it from under the tube. Then the bevel stays above because manipulating from the inferior might be a little tricky. and then it's just inserted as usual. So I insert a little posterior because the limbus is really a little unpredictable when you have small children. So with multiple surgeries, this is how it works. Then there are challenges of tube placement in case of post-PK. So this baby, this newborn comes to us, again intractable glaucoma, one eye clears, persistent corneal opacity in the other, OPK done, and then it's gifted right back to you with a post-PPV glaucoma. So the one thing that we've learned is that you have quite a lot of host cornea to keep in mind. Posterior is not so much an option here because they are phakic, and I would hate taking out a lens in a small child because the embryogenicity is so much more. But one little thing we've learned is to just keep the tube under the host cornea. So you do have quite a lot of host cornea under which you can keep the tube, and spare the donor from having the tube underneath it. So even though theoretically decompensation can occur in the host and go on, but then the chances would be a little minimized. So she's done all right. She's about 3 years old now, and so far so good. So sometimes we have no choice. We need to keep it in the sulcus, especially the analogous to IC in children would be axon-filled riga, where you have extensive posterior synechiae. If it's a pseudophakic child, there's no problem. So like Dr. Harsh showed, we just, and Dr. Pandav also, that we just put the tube in, leave it a little long so that you can see a little bit of the tip in the pupillary area, and insert the tube there, and that's about it. Now the tricky part is in phakic patients. So sometimes this is severe iris hypoplasia. You can actually see the edge of the lens. This is not aniridia. This is a severe hypoplasia sometimes which you see in progressive axon-filled riga, and surprisingly some of them do progress. So what we did was we put this right in the sulcus under the iris, but it is just abutting the lens, and I'm a little worried that this lens it's a little longer than what I wanted, but sometimes you can put it just in front of the lens and hope that it does well. But sometimes you can't do that as well. Another boy with extensive pars, intractable glaucoma, so you can see this, agonioscopy is important, but he's phakic. But I didn't want to put this into the anterior chamber at all. Since he was phakic, the posterior did not have an option. So what we did was with the vitrector made a little peephole so that I could put it in the sulcus and see the tip of the tube in the postoperative period. So that was interesting, and we now call it peephole. So in fact, sometimes in the OT list it's written peephole Adi. So this is what it looks like postoperatively. So you can see that little bit of tube, that's the lens, and it's still clear. So I like to keep the lens clear as soon as possible, and of course you keep it away from the cornea. So it's in the sulcus, but there's a little hole for you to see it. Now what Dr. Harsh was saying is so important. Now this was a vitrectomized eye. Now if this is vitrectomized, you sort of tell yourself that all right, then I can put in a tube in the sulcus. But the lesson we've learned is to do a skirt vitrectomy even if your eye is vitrectomized, because you're not sure what they have done and whether or not they have really gone under the iris and done a vitrectomy in that area. So this, on the first post-op day, look at these vitreous strands going in, which we didn't see on table. So we had to take it back pretty much early. You can see the vicryl is still there. And just a simple anterior vitrectomy, clearing out all those strands, and it's nice to do it under retroillumination because then you can see all these strands being cleared off from the tip of the tube. And post-operatively, this is how it looks rather than this. So it's absolutely clear of vitreous, and then you can sleep a little better. So the lesson we've learned is we go in with the, if it's a vitrectomized eye, we go in with the vitrector, go under the iris and clear out all that area in the pars plana, and then only put in the tube. So we try to avoid a patch graft in some of them, but in the stretched scleras, it's a double whammy. It's difficult to dissect, and yet putting another scleral patch graft on it sometimes causes more of a foreign body reaction in children. So this is a small microcrescent that is available, and we try to fashion a long tunnel. You have to make a small scleral pocket anteriorly, and it threads in nicely. So to avoid a scleral patch graft, sometimes a long track is used, And Dr. George Puthran has published extensively. So this is what it looks like next morning if you don't put in a scleral patch graft. But Dr. George has done a lot of work in doing a long track. Just a small caveat at the end. Dr. Sharon Friedman and her group has actually designed a calculator app which calculates where you should suture your plate in case you're doing it in a small eye, and it's a formula which is based on the axial length, and these are the calculations available. But it's very interesting that when you have a small eye, when you put in that big plate of especially the ADI or the AGV, you're actually going very, very close to the optic nerve. So the idea is to use this calculator app and actually calculate that you need to sometimes put it further than your 8 or 9 millimeters in adults. So the take-home points would be a tube entry as far as possible from the limbus as you can. Cover it always such that the tube is parallel to the iris. Secure the plate, well-buried sutures so that the children don't rub. And tell the parents that they have to partner with you and take care that the children don't rub it too much. Thank you very much. No, I didn't use. That's a good idea. Yeah, good idea. I didn't do it in that, but yeah, now I just do a big vitrectomy. Yeah, correct.
Thank you, ma'am. An extensive and good learning for everyone.